Good morning. Okay, to start off with, for the learning objectives, we're going to learn about the potential postoperative complications in patients who undergo breast surgery, and then identify strategies for prevention and management of these. And I'm going to my part will talk about this in a couple different ways. First, I'm going to talk about the general complications that can occur in any breast surgery. And then I'm going to talk about the complications that are specific to particular procedures. So for infection, the risk factors are the same as really for all operations. Older age, the more extensive surgery. So in this case, like there's a difference in infection rate between mastectomy and lumpectomy. And if you do mastectomy and reconstruction, the complication rate or the risk of infection is even higher. Where the risk of infection is higher if they had an open biopsy before, as opposed to a core needle biopsy, obesity, diabetes, and smoking. They've done several retrospective studies on perioperative antibiotics that suggested benefit. However, randomized control trials, some showed no benefit and others showed a benefit. But a meta-analysis where they brought all the trials together and looked at that revealed just a small reduction in infection rates with perioperative antibiotics. So generally, if there is no benefit to prolonged antibiotics. So we're talking about just a one-time dose in the operating room or just before the surgery starts, but no prolonged use afterwards, because that just promotes resistance to infection. So the bottom line is that infection rates really varied by study, and that could be different institutions have different levels of safety protocols in terms of infection control. But careful attention to sterile technique is essential, and consider prophylactic antibiotics in patients with risk factors. Hematomas. These can be very difficult to deal with because as surgeons, unfortunately, we've learned when you get a hematoma within the breast, it quickly sort of clots and becomes very thick or gel-like, and you can't aspirate these hematomas out. If they're very small hematomas, we can let them sort of dissolve on their own, but it takes a long time. If you get a hematoma under a mastectomy flap, you almost always have to take them back to the operating room, open up the mastectomy flaps, wash it all out, look for any bleeding, which you've probably started just doing that, and then close them back up again. But the rates vary in studies from 2 to 10%. Some probably also related to how meticulous people are with hemostasis and how extensive the surgery is. The use of, they have tried in just like lumpectomy procedures or biopsies to put some deep sutures in, approximating the tissue to see if that lowered the rate. But mostly what that does is it causes a distortion of the breast tissue that becomes apparent when women sit up, because their breasts are in a different configuration when they're lying down. If you approximate the breast tissue like that and then they stand up, the tissues can't rearrange themselves in the way that a breast would normally be shaped. And it causes fat necrosis. And fat necrosis will often calcify. And then if women have mammograms afterwards, you'll see these calcifications on the mammogram, which could just be from fat necrosis or could be from a recurrence of cancer. So we try not to use any deep sutures. So the most important thing is to assure hemostasis prior to closure. Even so, as women get up and move around, the breast will bounce and move around, and that can knock clot off a vessel and start some bleeding again. So having them wear a very supportive bra for at least a week after surgery, and try not to do a lot of bouncing activities for a few days, like no high, if they have an exercise program, make sure that exercise program doesn't jar the breast around, and avoid aspirin in the perioperative period. Then seroma, which we talked a little bit about yesterday. So seromas after modified radical mastectomies require that actually require aspiration vary from 10 to 80% of patients undergoing mastectomy and axillary dissection, depending upon what study you look at. It's a huge range, isn't it? So in some cases, some of these studies, they had not used drains for very long. They took the drains out very quickly, and the rates of seroma were much higher. Higher BMI is a risk factor. So thinner women have lower seroma rates than heavier women. Thicker skin flaps, where you're actually leaving some breast tissue underneath these skin flaps, will increase the interstitial fluid that seeps into that space between the skin flaps and the muscle. And so that will increase the seroma rate. So keeping your skin flaps thinner, staying in that superficial fascial plane between the subcutaneous tissues and the breast tissue will help. And assure the drains are functioning. Because really what you need, as long as there's a space there, you're going to get a weeping of fluid into that space. So what we really need to have happen is for those skin flaps to adhere onto the muscle and chest wall back behind, and then you'll no longer have that fluid seeping into the space. So assuring the drains are functioning well, allowing the skin flaps to adhere is key for this. And I can't tell you how many times back home and here I'm walking around and seeing patients, and the containers that are supposed to be pulling the fluid out aren't charged. They aren't compressed so that they can pull the fluid out. So it's really important to make sure that those are working correctly. And then, if you pull the drains, interestingly enough, we used to keep patients in the hospital until their drains got down to 30 cc's over 24 hours, and then we pull their drains and send them out. But the trend in the United States has been to send women out with the drains in for probably about 15 years. And in fact, a lot of women go home same day as surgery now with the drains in. And when they go home, we tell them to wait until it's been down to 30 cc's over 24 hours for 2 days in a row. And our seroma rates went down. I think that sometimes, when they're in the hospital, they're not moving around as much. And so you're not getting as much fluid production. And so, often they'll come down much faster in the hospital. The amount that seeps out will come down much faster in the hospital. And we're actually pulling the drains and sending them out before the flaps are really adhered. And they go home, and now they're moving around a lot more, and they get more fluid production. And that might also be why the seroma rates can be high. I don't know the possibility of thinking in the future of how you could train women to be able to go home with the drains in and leave them in a little bit longer, because I know it gets hard in terms of patient beds, having the room to keep them in hospital for 7 to 10 days. And that's often how long it will take for those the flaps to really adhere and the fluid to go down. And once you pull the drains, there's always some fluid. Of course, we know that they were still getting about 30 cc's or 25 cc's a day, right? So that's not going to magically stop when you pull the drains. So you're going to get some fluid that accumulates there. The idea is that once you pull them, the amount that's going to be accumulating is going to be only a small amount, and that will reabsorb over time. But if they start to develop a lot more, then they need to be aspirated. And you need to keep bringing them back every few days and aspirating that so it doesn't accumulate into a larger amount. It's once you start to develop that sort of fibrous coating on the inside that of a seroma that surrounds it, it'll keep weeping forever. So it's for a long time. So it's really important to get those flaps to adhere. And so again, I can't impress enough amongst everybody to keep an idea to make sure those things are always charged and not looking like this. When they're not pulling fluid out, it's all passive. And even then it's kind of hard for it to drain. Then you can get also seromas after just doing axillary surgery. So when you're doing like lumpectomy and axillary dissections, the axillary dissection is through a separate incision, of course, tucked along the lower hairline of the axilla, and you go right in and you do your axillary dissection. You might also be doing it that way if you have a patient that comes and they've had a mastectomy elsewhere that didn't do the axillary dissection, and now the patient needs an axillary dissection. Well, you're not going to go back through the mastectomy incision to do that. So you make an incision along the lower hairline and go in and do the axillary dissection that way. Once you close up, all those lymphatics that were draining up from the breast and the surrounding tissues through the axilla there, and even some from the arm, that you're going to develop a seroma within the axilla. When we first started doing these axillary dissections with lumpectomies or axillary dissections separate from the mastectomy, we always put drains in the axilla. And then we tried doing studies where we randomized women between drains versus no drains. And what we found was that the rate of seroma formation, whether it be after the drain is pulled or leaving it alone, there was less seroma fluid aspirated, the need for it, in those who had the drains. However, the same number of patients had a prolonged need of aspiration in both groups. So in other words, for those women who only had some fluid that accumulated, the drains took care of it, and others would have it aspirated. But for those that tend to have a lot of fluid produced, having the drains in there didn't seem to make any difference. Once you pulled the drains, they still required prolonged aspirations. And the number of women requiring those prolonged need for aspirations was the same regardless of drains. The hospital stay was shorter in the group without drains. There was less pain in the group that did not have drains. And there was no difference in complications. So we actually stopped putting drains in for these axillary surgeries after these studies came out. And if there's only some fluid in there, avoid aspirating it, because sometimes a little bit of pressure from that fluid actually helps those lymphatics to seal. So allowing a little pressure in that axilla is good. So we only use drains for mastectomies now. Persistent pain may occur with mastectomy. It can occur with lumpectomy. It can occur with open surgical biopsies. I've even seen it occur in women who had core needle biopsies, and they get persistent pain. It's likely neuropathic. It's from subcutaneous nerve that was damaged or cut, and then develops either a neuroma on it or just continues to be inflamed and send a signal. If while we're doing the surgery, we see a larger sensory nerve, it's best to transect that at the very edge, sort of pull it out a little, tie it off, and let it so that the tie actually can retract back into normal tissue once you once you cut it off. It could be if it continues and it doesn't seem to be improving, gabapentin or a serotonin reuptake inhibitor can be useful in terms of decreasing this, as it is on neuropathic pain. And there are some women that people have gone back in and done repeat surgeries trying to resect the area, thinking they might be able to resect whatever it is that's causing pain. And often the pain recurred after treatment. So surgery, unless you have a definitive neuroma that you can define exactly where it is, going back in and performing surgery for this is not useful. Deep venous thrombosis. People, all of our patients with cancer are at increased risk. But fortunately, we've been able to keep these rates pretty low nowadays. Early ambulation, in the States, we have these things called venous compression boots. They're these plastic boots that you Velcro around the lower legs, and there's a pump that just sort of massages, lets air in and out, in and out, in and out, and massages the calves during surgery. And that actually they're not really sure exactly how they work, actually, but the thought is that it keeps the blood moving back and forth in the veins enough that it decreases the risk. But we avoid heparin due to bleeding complications. So you hate to have to heparinize someone for a DVT after you will, if they could develop a DVT, you will have to anticoagulate them, but preventing them is the best thing to do. Oh, there, and I worked with an anesthesiologist who there was a study that was done that shows just putting a blood pressure cuff doing the same thing, going up and down on the cuffs on the calves can do the same thing. So without those venous compression boots, if you have someone you feel is at higher risk of DVT, maybe they've had a history of them in the past, you could always try just putting getting a couple of blood pressure machines extra and putting one of the larger cuffs around the calves and try doing that instead and just have it go up every couple minutes. Mastectomy, when we do a mastectomy and we go to close that incision, sometimes, particularly not so much on the thinner women, but the women who have a little bit higher BMI, are on the two ends, you might have these little extra dog ears that come out. And we call them dog ears, but they're sort of redundant skin where you couldn't extend the incision even longer because you get into the other, get over to the other breast, or you're starting to take it around the backside of her chest. So there are several techniques to actually remove those that don't require lengthening this incision. And that's what we should do. The important thing is not to lengthen the incision further, because if they end up getting radiation, the radiation field has to include the entire incision. So if you really extend that incision, they're going to get more lung volume underneath that is treated. And if it's on the left side, more heart that is treated by the radiation. Skin flap necrosis. So the blood supply to the skin, once you've taken the breast out from underneath, the blood supply to the skin used to come up from perforators through the breast tissue. Now you've taken out all those perforators and the blood supply to the skin has to trickle in from the far edges. And sometimes it doesn't get all the way to the center. And you'll end up with some areas of skin necrosis. Avoid the tight flaps. The tighter the flaps are, the greater the pressure in the skin. And so that'll make it harder for the blood flow to get all the way to the center. So the important thing is measuring out ahead of time how you're going to do your excision so that you take enough skin that you don't have redundant skin on the chest wall, but you leave enough skin that those aren't tight. It's a little more difficult if somebody's put the biopsy incision in the wrong place, because if they put it way low or way high, then you have to include that biopsy incision as well as the nipple. And then you end up resecting a lot of skin that you might not have otherwise wanted to resect. And you have to figure out ways to get it closed so that it's not under as much pressure. The necrosis is also at higher risk in smokers and people who have had prior radiation. When you get skin necrosis, sometimes at first, it's not really clear if it's if it's completely dead or just ischemic. So leave it alone and wait for it to declare itself. Sometimes it'll look really, really dark and you think, oh, this is dead. Don't take them back to the operating room right away. In fact, we often don't have to take them back to the operating room at all. If you end up with skin necrosis there, it often will dry up into an eschar, and over time will heal in under and lift the eschar. So just see them back in the office and keep trimming the eschar as it heals in. The only time you have to actually excise it is if you start to get infection in it. But generally, if you keep it dry and clean, it'll end up into an eschar, and you just keep trimming the eschar as it heals underneath. It can take a long time to heal underneath. You should not need to delay chemotherapy for this. So if you have skin necrosis and it's clean and they have a dry eschar there, just go ahead and start chemotherapy. But continue to see them in the clinic every week or two to trim the eschar back. Mastectomy, just adding reconstruction almost doubles complications. It's more extensive surgery. So it's a higher risk for all of the complications. And if they have bilateral surgery, if they're doing it on both sides, the risks are even higher. Reconstruction can be done with implants, but it can also be done with flaps of tissue that are brought around. When you bring flaps of tissue, you can either swing them in on their blood supply, but there's a risk of that the blood supply becoming compromised and getting necrosis in those flaps. And there's also, you can bring them in and do microsurgery and sew vessels together, and there's a risk of those clotting off. Also, when you're bringing in flaps, even if the blood supply is fairly good, there could be areas within the flaps that end up developing fat necrosis because of different angles or sutures that you put in there. And that fat necrosis can become hard little nodules that then the patient gets sent back to you because people are wondering, is this recurrence of the cancer? And you're trying to figure out if it's fat necrosis or a recurrence, and you often have to biopsy it or do an aspiration. Lymph node surgery, of course, as we discussed yesterday, is the greatest morbidity. We went over the short-term and the long-term problems with it. Cording, just to discuss it a little bit further, is most prominent in the axilla. When women raise their arms, you'll see this, it almost looks like a string underneath the skin that's very taut, and it's tender, it hurts. And sometimes it will extend down the arm toward the antecubital area. And really, it's just a thrombophlebitis of a superficial vein. It will often resolve on its own. Just sometimes you can do heat and cold alternating. Aspirin may help. You just don't want to start that too soon because you want to make sure the wound is well healed so you don't develop a hematoma. Then there's lymphedema. Those arm lymphatics, as we discussed yesterday, mostly surround the axillary vein. So staying off the axillary vein during your dissection is really key. Now, we used to always teach to identify the axillary vein, but you're dissecting in and around those arm lymphatics to identify the axillary vein. There's no need to identify the axillary vein as long as you identify the intercostal brachial nerve, because that intercostal brachial nerve will always be a 0.5 centimeter to 1 centimeter below the axillary vein. You know it's there, so there's no need to disrupt those lymphatics to show it. Go to the intercostal brachial nerve, then go straight, then dissect everything inferior to that. Don't go above it. The breast is going to be pulling those contents down, so tensioning them down. So it's going to be pulling some of that tissue from the axillary vein down. It's real easy to then take more of the higher tissue there that have the arm lymphatics than you want. So, support that breast tissue so it's not pulling that down so much. And just keep in mind constantly as you're doing the axillary dissection to stay away from those lymphatics unless you have to go there because there are suspicious feeling nodes. If you feel any nodes up there that feel suspicious, you have to take those out. And then, of course, post-op hematoma around the axilla will increase the inflammation, which will increase the risk of fibrosis of lymphatics, and the risk of lymphedema can become higher. Post-op infection, same thing, increases inflammation, which can increase fibrosis and cause an increased risk of lymphedema. So avoiding those things will help a lot. This is yours, yeah.
Thanks, Susan. So I'm going to be talking a bit more about lymphedema with all of you. We're going to be talking about considerations for long-term prevention and management of lymphedema. So this is a pretty relatively common side effect or outcome of surgery, of breast surgery. So in patients with a sentinel lymph node biopsy, about 6 to 8% of those patients may develop lymphedema. And then in patients with axillary lymph node dissection, it's estimated to be about 13 to 50% of those patients to develop lymphedema. So just wanted to review the classifications, the staging of lymphedema. So there are 4 stages. So stage 0 is subclinical. So the patient is not yet experiencing symptoms, but changes in lymph flow could be found on imaging. Stage 1, so this is where the patient has now developed a visible swelling of the limb. So if you compare one arm to the other, the one would have some swelling and enlargement. and this could include pitting edema. Patients often report that the arm feels heavy. They might have some numbness of the arm. And really important to note is that at stage 1, elevating the affected extremity, so elevating that arm, usually solves or at least relieves symptoms. And this is important because we really want to catch patients when the lymphedema is at this stage, because if we are not intervening appropriately at this stage, then patients can develop, can progress to further stages, and ultimately could end up having a chronic or lifelong lymphedema. So stage 2, essentially the same presentation as stage 1, but notably the elevation of that arm is not going to solve or relieve symptoms. Stage 3 is the chronic stage of lymphedema. And skin changes at this stage might appear with hyperplasia, fibrosis, lichenification or thickening or hardening of the skin, and secondary ulcers as well. So we really want to do what we can to prevent lymphedema. We can't always prevent it from occurring. But prevention, patient education and surveillance is really important. So patients should, after they complete surgery, should be aware of the potential of lymphedema and should know what are the signs and symptoms so that as soon as they notice the development of lymphedema, that they come back to clinic so that we can appropriately manage the lymphedema so it does not progress any further. Exercise can reduce risk, so encouraging exercise post-operatively can be helpful, and alternately being overweight can increase the risk. So in patients that do develop lymphedema, how do we manage those patients? So immediately upon detection of lymphedema, patients should be advised to elevate the arm and return to clinic. Really critical to avoid blood draws or IV starts in the affected limb as soon as lymphedema has occurred. This can be really challenging in oncology patients, particularly if they are receiving chemotherapy, neoadjuvant chemotherapy, or adjuvant chemo. Over time, it can be difficult to find appropriate IV access. And so in these patients, it might be appropriate to advocate for a central line. I know we don't do that frequently here, but really important that we are never using the affected limb for IV starts or even blood draws. And then additionally, avoiding blood pressures in that arm. Meticulous skin care is really important. So patients should be performing good hygiene of that arm, making sure the skin is hydrated. And then if there is any break in the skin, managing that really carefully. Any break in the skin with lymphedema can really quickly lead to a cellulitis. That trapped lymph fluid creates an environment where bacteria can really thrive, and that cellulitis can really quickly lead to sepsis. So really important that we are, 1, preventing any breaks in the skin from happening, and then 2, if it does occur, managing that very carefully. Compression therapy can be helpful in patients with lymphedema. So bandages or sleeves can be worn. This can help to reduce volume and prevent progression of early stage lymphedema. And the idea here is that we want to gradually decrease the pressure gradient from the highest point in the distal wrist to the lowest part in the upper arm to help facilitate the movement of the lymphatic fluid upwards. So really patients should be fitted for compression bandages or sleeves by physiotherapy, just to make sure that this is done effectively. So again, we're not always going to able to prevent lymphedema from occurring, but there are things that we can do to prevent its progression and to prevent complications such as infection, which can be really morbid in these patients and really impact quality of life. So really important that we're always following these prevention and management strategies for lymphedema. I'll hand it over to Justine.
Dumalang. Okay, so I will touch lightly on seromas. So we've been discussing seromas even since yesterday. So why do we care about seromas? Ultimately, they can, if we don't intervene quickly, they can delay care, cancer treatment. They can cause infection. So if we detect it, it is important to start to intervene. Ultimately, management is based on the severity of the seroma. The seroma assessment, usually it's a soft lump under the skin. If you can gently press on one side of the lump, it may reveal a wave-like motion of fluid underneath the skin. It sometimes can be tender to touch, and sometimes clear or yellowish discharge from the incision may be present. Another thing that you can teach patients, if they start to form a banana-like shape under their incision, that could be a sign of seromas. So, like I said, the management of seromas is primarily guided by the size and the severity of it. It is a stepwise approach. So we want to observe for any small or asymptomatic seromas first. And then if they start to get worse, you would like to aspirate for them, or even escalation to drain. But these are the management modalities that we have. We could aspirate. Some studies support sclerotherapy. We may have to do surgical removal. And also, there's some studies that prove that early mobility versus delayed mobility to help the seroma formation. Just like Susan said, it really matters about the skin adherence to the muscle wall. So as long as the adherence is successful, the patient can start to do their normal range of motions and even exercise. So the summary of our whole presentation, everything we do has consequences, risks for the patients. Attention to detail may help to decrease the risk but risk still remains. And we should do more than the data. We should do no more than the data supports. Also, as clinicians, we could perfect our technique, but also the patient education piece is just as important. The patient is part of the healing process. So as clinicians, it is our job to provide that patient education, and they actually receive that education back home so that they don't come back to us. So yeah, that's really it. Any questions from anyone on any topics that we touched? Any experiences in our practice